solutions to it. So asanteni sana. Okay. All right, a very good morning to you. It's so good to see you. This is, I want to say, a town hall forum, and we're coming to you from Maua in Meru County. Beautiful, beautiful county, if you ask me. And today is such a special day because we are celebrating World Cancer Day, and different countries across the globe are actually marking this day, and that is World Cancer Day. And the biggest, conversation this morning is finding solutions to cancer, because we have talked about cancer for a very long time. And if anything, the numbers are not, encouraging, if you ask me, and especially when we're talking about Meru, which we'll focus on in just a second. But just to bring you up to speed on the theme, we have a theme that has been running since 2025 up until 2027 on World Cancer Day. And the theme is United by Unique Places, People at the Center of Care, and their stories at the heart of the conversation. And the aim really of this conversation is to ask a very simple question, and that is, what does it take to deliver cancer care that genuinely meets people's needs? So that is one of the questions that we'll be seeking answers to today, right here in this forum. We have an audience, but I also have my panelists joining me this morning. And just to give you a little bit on the numbers, especially from WHO, especially in the African region, where they say that cancer is becoming one of the leading causes of premature death. And they say every year, more than 1 million new cases are diagnosed, and nearly 1 million people lose their lives to the disease. And we're saying behind these numbers, just, the disease, are mothers, these are fathers, these are children and young people whose lives are unfortunately cut short, not because solutions do not exist, but because access to those solutions remain unequal. And that is the conversation that we're having this morning right here in Meru County. And specifically, we're actually coming to you from Maua Methodist Hospital, who are very, very kind enough to host us this morning. We have Professor, the CEO here joining us. He is in the panel. We'll be getting to say hello to him in just a second. But also just on a bigger scale to understand Meru, because Meru, there was a study that was done, I think in 2019, and they found out that Meru, they actually call it the hotbed of cancer, okay? And we have a village that has been called the Cancer Village. So what is it? What is happening in Meru? What is it that we need to do to either prevent or help manage cases of cancer right here in the county? So this is a conversation at the right place and at the right time. So really be sure to join us until the end of the conversation. And we're not saying this is our conversation. This is our conversation as well. So if you're watching us at home, a simple question to you is, have you ever been screened for cancer? Okay. Have you ever just gone to a hospital to just say, listen, just screen me, okay, for cancer? Or most of the time, we're scared. Kwa nini nikienda hospitali alafu niambiwe iko? Nifanye nini, okay? So we'll be seeking answers to those questions as well. But just a question to you is, have you ever been screened for cancer, or have you ever gone to a hospital and just have a conversation on cancer? Matt, let me introduce my panelists this morning. And I am going to start with the host, the one who has hosted us today. If he says, Ninyi wote mwende nyumbani, tutaenda nyumbani. But he said, no, sitawafukuza, mko hapa, okay? We have Professor John Mungania, who is the CEO of Maua Methodist Hospital. How are you? Good morning, sir. Thank you so much for joining us. And thank you for being gracious enough to host us this morning. We'll get to hear a little bit about Maua in just a second. And then I'm going to go all the way to my far left, where we have Dr. Griffins Omodi, who's a medical director, Maua Methodist Hospital. Good morning.
Yes, good morning.
Thank you. Thank you so much for hosting us as well.
Thank you so much.
This morning. And then next to him, we have George Oguta Obonya, who's a clinical oncology and palliative care officer joining us this morning. We cannot talk about cancer without having an oncologist. Thank you so much, George, really. It's so good to see you again. The last time I saw you was in Nyeri. Good to see you again. And we also have Mr. Mutugi Murithi, who's a Christian Health Association of Kenya Director, Health Programs. Good morning. Good to see you.
Good morning.
Karibu sana, and thank you for joining us for this important conversation. And next to me, we have Agnes Mugambi, who is a breast cancer, I want to say, warrior. Tumpigie makofi. She is here today, bold enough as well to share her journey with us. Agnes, it's so good to see you. You look amazing. I really like this color on you.
Good morning.
Thank you so much for making the time as well. Professor, can we just start with you? Tell us a little bit about Maua Methodist Hospital and why this conversation today is important to you, not just as an individual, but also as a hospital.
Thank you very much, and much welcome. Before I read my short speech, I want to bring the apologies of Governor, His Excellency Reverend Isaac Mutumanto Edingia. They're having a meeting in Mombasa, so they couldn't make it. And of course, I want also to bring greetings from other guests who could not make it. This morning, I'm happy really to recognize some of our chief guests here. And besides the panelists, among us, we have my vice chairman, who is Bwana Kenota Anampio, and we have other ministers. We have several of our board members here present, and therefore this talk is supported by all of us as the hospital and the Methodist Church in Kenya, because our presiding bishop is the chairman of our board. And it's also representative of the council of the county, because 3/4 of our members, board members, are staff members of Meru County. And therefore, Madam, as we continue this discussion, I am Professor John K. Mungania, the Chief Executive of Mount Methodist Hospital, and I'm delivering this cancer awareness town hall meeting talk today, the 4th of February 2026, at our place here, Mount Methodist Hospital, which is in Meru County. Distinguished guests, esteemed panelists, valued partners, as you are very many here, and the sponsors, colleagues, members of our community, and all those following us through social media and NTV. On behalf of Mount Methodist Hospital, I warmly welcome you to this Cancer Awareness Town Hall Forum. It is a privilege, so to speak, to host this important gathering. Cancer is no longer a distant concern. It has become a lived reality within our homes and the communities. As a faith-based institution, Mount Methodist Hospital has served Meru County and its environs since 1928. That's when we were established, with an unwavering commitment to holistic health care. Located here in Maua Town, Igembe South Sub-County, Meru County, we are registered level 5 hospital, and we are accredited by the Social Health Authority, the famous SHA, and we also work closely with the leading corporate insurances or insurance providers to address the health needs of our people. Our mission goes beyond treatment. It embraces awareness, prioritizes early and detection, and it delivers compassionate care to every patient we serve. In addition, we provide holistic support through our chaplaincy department, offering pastoral care and psychological counseling to patients and their families. Cancer continues to pose a major public health challenge in Kenya. Among women, breast and cervical cancers are most prevalent. Among men, prostate and esophageal cancers are leading concerns. Yet, behind this data are real people. Lives that can be safeguarded through through timely information, regular screening, and access to quality care. At the Meru Methodist Hospital, we are dedicated to advancing the full continuum of cancer care. This commitment is anchored in 4 strategic areas. The first area, or area 1, community education and awareness. Area 2, screening and early detection. Area 3, diagnosis and treatment. Area 4, palliative care and support. Together, these pillars form the foundation of our approach. They ensure that hope and healing remain central to the services we provide. This mission, as explained, cannot be accomplished in isolation. Meaningful impact require strong and deliberate partnerships. It calls for unity among healthcare providers or institutions, health financing partners, the media also, faith organizations, and the community. We extend our sincere appreciation to our sponsors, our partners, and the friends of Meru Methodist Hospital for their commitment to this cause. Among these valued collaborations, NTV deserves special recognition for amplifying cancer awareness beyond these walls and carrying our message into households across the nation. Their contribution exemplifies the transformative power of partnership. That is, turning awareness into action and impact. Guided by today's theme, United by Unique, may this forum inspire collaboration, practical solutions, and a shared responsibility in confronting cancer within our community. As the African proverb reminds us, sticks in a bundle are unbreakable. Let us also be guided by the timeless truth. If you want to go fast, go alone. If you want to go far, go together. Our fight against cancer is not a sprint, but a marathon. A journey we must undertake with the collective endurance and the shared strength. Let us stand united, each bringing our unique gifts, resources, and voices, knowing we are stronger together in this fight. It is in this spirit of unity and a shared purpose that we at MMH, Meru Methodist Hospital, are taking a significant stride forward. We are now focused on completing our new modern oncology unit. This facility will stand as a testament to our collective commitment and a dedicated space where cutting edge meets compassionate support for every patient and the family on this journey. I thank you for your presence and commitment. Together, we can transform awareness into action, and we extend our appreciation to all those joining us through social media platforms and NTV in particular, in across borders, for being part of this collective effort. I now officially welcome every guest, professional, survivor, caregiver, and the community member to this vital forum. Please feel welcome.
Ladies and gentlemen. Thank you so much, Professor, and really congratulations, for the fact that you're setting up an oncology, wing. That's a really, really good thing to hear this morning. And Dr. Griffiths, just to pick up from where Professor has left, can we talk about the burden? Because like I said in my introduction, Meru County has been termed as the hotbed of cancer. So how much of a burden is it? And just what you deal with on a day-to-day basis right here at Maua Methodist Hospital.
Thank you. Thank you so much for that question, because it's a question that makes my heart to bleed, particularly when I have to talk about it. And I hope that with continuous awareness, our hearts will stop bleeding when we act. So here in Meru, it is a hotbed, as has been referred to, of cancers. Has been commonly known as a hotbed of particularly cancers of what we call the GI tract, the commonly known digestive system, for those who do not understand the GI tract. And actually, there is an area around us, not several kilometers from here, which has been referred to as a cancer village, because there, relatives say, if you get to the ground, at least everyone there has a relative who has either died or is battling cancer, as opposed to where I come from, in a different place, where I can't actually put a finger to a particular relative who has died of cancer, let alone those who have it, because that I may not be able to know that. So there's a complete contrast, and that is why we have, here at the hospital, previously we have lots of cases of cancer patients that comes to our casualty, and they need adequate care. Unluckily, almost all of them present late by the time we get it, unluckily. Here, I can say over 89 to 90% in a rough estimate will always come late. To 90% of the people we actually end up making diagnosis here, they always come late, and we barely find anyone early. Number two, when they come, most of them are actually, probably that is the time then we play catch up in registration to particular insurance companies, and they're also poor. It's difficult to actually get to start processes. Remember, even as we deliver services, we are a mission hospital, and we tend to care for everyone, but we also incur expenses. In doing that, we end up even getting some things called uncompensated care because of these patients who can't do it. And a perspective to it is that we act blood that we consume. And most of our blood actually gets to transfusing cancer patients who actually need to get optimized for chemotherapy and radiotherapy. And most of them actually, not a lot, that we are able to actually get blood. You have to really source it from elsewhere, do campaigns about it, and we have consumed. We are actually second to the county referral hospital. That means we are actually the largest private entity that deals with cancer cases, private or faith-based, under that category, that deals with cancer cases. Yes.
Are there any specific types of cancers that are more prevalent here? I mean, I was doing a bit of reading and they're saying stomach cancer, esophageal cancer, and probably this is a question for you, George, in terms of understanding, first of all, why the specific types of cancers are more prevalent, but also just to pick up on what he said, that 80 to 90% of patients come a little bit almost too late. So what can we attribute that to?
Yes, thank you so much, Winnie. Today is 4th. I want to start from the date today. Today is 4th of February. And in the whole world, we celebrate and commemorate the day. Today is a Cancer Awareness Day. And not only other cancers, but more specifically with the mesothelioma and cancers that are asbestos caused. I'm happy the prof, when we had a discussion out here, he talked of the roofing that is ongoing in terms of renovation within the facility. That is part of awareness and also part of eradication of these cancers that can be completely be preventable. Now, I'm also happy that we have another panelist here who is a cancer warrior. And this is a testimony that cancer is treatable, and we should not be stigmatizing our patients, because I think this is also another reason why they don't come to the facilities early, because they fear that what happens after being diagnosed. Am I going to die, or what happens thereafter? Now we have an example here that cancer is treatable and this thing is beatable. Now this region, Meru and Mount Kenya, has been recorded in terms of high numbers of GI cancers. I think most of the researchers are going on. Currently, we cannot attribute it to, some other risk factors, though there are things that have been alluded to that. But there are many scientists going on with the researches. I think within the shortest time, we'll get to know what is the cause of all this. And I just want to appeal to all of us, like today being the 4th of February and any other day, let us spread the news and the word out there for the cancer awareness, and also in terms of the health-seeking behavior. And also to the health workers, I can see the room is full with the health workers. Let us also increase our capabilities of, the high index of suspicion, so that we can screen these patients, do some thorough tests on them, some thorough investigations, so that we can pick these cancers early. And again, that is going to help us in terms of management. Thank you.
Thank you so much, George. You know what? Again, during my reading, I came across different theories, and this is from Camry, who came here on ground and they were talking to people, and they had very interesting theories. And one of the things they said is they suspect maybe, in 1945, there was a meteorite that fell in Meru. So they're suspecting that maybe it contaminated or poisoned the water. They were also saying maybe the soil was contaminated, by the bones that were buried during the Mau Mau, uprising. So there were so many theories there, which we'll come back and talk a little bit about. Because again, like you said, there's no specific thing that can be attributed to the reason why we are having a lot of cases of cancer, especially when we're talking about GAT. You want to add something very quickly before?
Yeah, very quickly. In terms of research and what is documented, most of the risk factors are associated with smoking, of cigarette, alcoholism, physical inactivity, exposure to chemicals. The other viruses like HPV that also causes cervical cancer. The other viruses like the hepatitis that are associated with the liver cancers. I think some of the things are partly they are myths, but partly they need to be confirmed through scientific examinations and all the researches.
I see. Okay. And Mr. Mutugi, before I come to you, let me speak to Agnes very quickly, because you talked about healthcare workers having high index of suspicion, and I was talking to Agnes earlier on before we came on, and you told me the first time you went to a hospital, they told you had something to do with maybe menopause? Mm-hmm.
Morning.
Good morning.
My story. I'm Agnes.
Do you want to speak closer to the mic? Yes.
Yes. Is it okay when it's there?
Yes.
I'm Agnes. We were talking about before I was diagnosed. And I told her that maybe I couldn't be diagnosed when I was in stage 1, but there was wasting of time. I started just a small thing like a joke. I could see a small water coming from my right breast, especially when I was washing or when I wear a bright dress, I could see just a stain. I was that time 56 years. I went to see a doctor because of that, because it was disturbing. There was no lump, it was not painful, but I was disturbed just by that water, small water around my nipple. Then I was told, I was given just Brufen, and then I was told it's because of postmenopause. And then it kept disturbing me for, I think, for more than 2 months or 3 months, until I went for mammogram. somebody somewhere, a friend, told me that you stay with him on Brufen and just being told is post-menopause, and maybe there is a problem which is not known. Then I went for mammogram, where it was done, and then they suggested I have biopsy, breast biopsy. It was done. I was assisted a lot by friends. They didn't take time. It took only 2 weeks, and then came out, and the result was positive. I felt bad. I blamed the person who was joking with me because I said it was a joke, that is menopause. Because I asked the other ladies if they are getting that water on their breast, nobody told me if they are getting the same. So the result came positive.
What was that moment like for you when you saw the results were positive?
I felt bad. It was not a good result, it was bad result. I just felt that cancer, because people have been seeing cancer, I was seeing people with the cancer, but I had never thought it would come to me. So I thought, maybe because with the cancer people die, I'm also on the way going. But with the counseling, support, and myself, because myself I accepted after struggle. I said yes. It has come to me, but God allowed me to fight.
You're here today. Thank you. Thank you really for coming by today and just sharing your story with us, because you're offering as much encouragement out there to people, because we were discussing about this earlier on, that sometimes people are scared to talk about it because stigma, again, like George mentioned, is still high. There's still a lot of misinformation and disinformation about cancer. So thank you so much, Agnes, really for coming by today. I have so many questions for you, but let me speak to Mr. Mutugi, and then I'll come back to you. Because Agnes mentioned, you know what, I accepted after a while, after struggle, and I believed that God is with me. And most of the time, church is where people go to find solace, to find encouragement. So can we just talk about the role of church when it comes to either cancer care, cancer prevention as well, and what really and what role really the church should play even more to help the people out there?
Thank you very much, Winnie and Tim. I'm glad to be here. I'm Dr. Mutugi from Christian Health Association of Kenya. Christian Health Association of Kenya, called CHAK, is a national faith-based organization for mission hospital, Protestant mission hospital like Meru Hospital. We partner with many Protestant mission hospitals across the country to deliver quality health care for all. That is our vision, quality health care for all. And in Northeast, we are an extension of the work that Christ did here on earth, which we say it was in 3 realms: preaching, teaching, and healing. And therefore, as Christian Health Association of Kenya, we have health experts there and also partner with those who are practicing in hospitals like in Meru Methodist. One of the things that we believe in is that beyond medicine, there is the aspect of health spirituality. And that is where our faith community comes in. And as our sister, who is really a warrior, cancer warrior, mentioned, that beyond the medicine or the treatment that she was given, there is the aspect of hope. So we believe there is an aspect of healthcare called health spirituality. And we partner with our churches, with our mission hospitals, that as we deliver care to our communities, there is the aspect of health spirituality that gives hope and encouragement, that at times patients upon diagnosis, those who maybe worsen, their cases worsen, is probably because of the aspect of lack of that encouragement. Faith has a strong component in our healing process, not just the medicine. I'm a doctor, yes, but we believe that spirituality has an aspect of healing amongst our patients.
But then again, how do you balance? Because, and I'm sure you've heard this, where a lot of people will tend to just lean on faith and forget medicine. And I'm sure you watched the news and saw, what just happened recently. So how then do you either encourage people or just help people understand that yes, faith is important, but also there's this other side of treatment that is also important?
Oh, great. And when I mentioned in CHAC, our maxim is the extension of preaching, which has a role. We impart knowledge about faith. Teaching, that is, we impart knowledge. And that is where we come in with the scientific knowledge and healing. And healing has the two components. There is a role of faith that cannot substitute the role of medicine. And therefore, we find as CHAC, we have combined the two. We have a group of doctors at mission hospitals. And also like here, what we learned, there is a chaplaincy department, has a role. So the two work hand in hand. And for us, we strike that balance that faith does not replace science. Neither does science replace faith. So the two have to work hand in hand, and we do not encourage maybe where maybe some of the faith, maybe healers, you see, discourage people or make certain pronouncements that are not probably supported by science. For us, we strike that balance, ensuring that our communities are able to benefit from the two realms. Medicine, which is largely based on science, and the aspect of health spirituality.
I see.
For us, having that, you give what you call holistic healthcare.
And equally important. And I think you mentioned partnerships, and Professor, you also talked about partnerships and how important that is. And even in your speech, you talked about what the hospital, Meru Methodist Hospital, is doing. But at the same time, can you speak more on the role of partnerships and how that has helped, Meru Methodist to, come this far, and especially when it comes to offering the right treatment to the people in the community?
I think that's a good question, madam. Partnership to us means a lot because, as I said, you cannot walk alone and reach far. So without other people joining hands, without other people, like, for example, our sister, being talked to and being told, yeah, you will live, I'm sure, then life will not be okay. So at the Meru Methodist Hospital, we are encouraging that. And that's why we are on department, the palliative care department, where we treat chronic diseases. And we encourage them to know that there is life. Even when they die, there is life even after death. So this is not the end of everything. And therefore, cancer being one of the sicknesses, it must be accepted, and the community must also agree to assist. That's the aim of the hospital, and that's why we are mission hospital. Because we want to encourage people to live like communities. In death, in whatever, they are together. And therefore, somebody is feeling that I'm not alone in this fight, actually will hand more days to his or her life. That's what we think as a Meru Methodist Hospital. And you have these partnerships. Even if it means, like, for example, we're having an oncology unit. We are not doing it alone. We have partners. And that's why we think without the partnership, even the prevalence of the sickness will be greater. And I believe we can strongly remove this stigma that the cancer, once you have it, you are dying. And then you are saying, let's try to tell people early enough that the cancer is not something to kill you. It's a sickness like any other. That's the idea.
I see that. And we'll also talk a little bit later about how important partnership is, and especially when it comes to making access to care affordable to so many people, because I think we can all agree that cancer treatment is not cheap. And a lot of people don't go to hospitals because they're like, I cannot afford this. So how, is partnership playing a role in easing, that burden? But Dr. Griffiths, very quickly, what trends are you seeing? Because we've talked about cancer, especially in Meru, for a very long time, okay? But are there maybe trends that are emerging that probably you're seeing in the hospital that you think should be highlighted?
Okay, thank you so much. Basically, as regards cancer and the trends that are actually emerging, not actually far beyond what has actually been documented, our trends remain as per national trends, where we still have breast among women being number one, and cervical coming up there. And among men, we still have prostate. That is still a huge thing. The only thing that may make it a little different here is probably our population. You realize that our population covers a big part. This Mawa is kind of like a terminus. Some of my friends joke of a terminus of civilization. If you were to walk this, you get into the park and probably now get into what we call Jangwa till to Somaliland, a greater part of it. So we have a little much more of low levels of education in terms of the people that we receive globally. Basically, I mean, if you look at the number of clients that we see, and that actually plays a big role, because number two, the belief that I can stay a little longer, particularly among a little much more of a cultural perspective of this context, where the men in this region actually believe they can stay a little longer. They can be a little stronger. And another last thing is actually when people come from those villages, they come in when they can't now survive anymore with what they perceive as their physical strength. And those factors actually bring to us, most of our patients will come extremely very late. And that actually is probably one of the most unique trends we observe. And the last aspect is also a good number of our clients, when they come from the perceived Jangwa or other a little remote areas, you find out that a 26-year-old does not have an ID. So there is no way you can enroll him into, even if you are to think about health system financing and other things, they're probably not even aware. So if you are to play catch up with an emergency patient, who needs that? So the fear of that, the fear of having no money and no insurance, despite other forms of payment being available. The last comment to that is actually a very big trend also for us is basically when we look at the general belief about sicknesses, the general belief about sicknesses in a bigger part of the community also still believe that there is a cultural perspective to cancer. There is something that someone might have done somewhere. A few patients who insist that I want to go back because there is something that has to be done by someone in the village for me to get healed. So before we make contact with these patients, there are a lot more delay. That brings us to the conversation that people believe may come later about early detection and other things. But one of the greatest things, again, about cancer is, I think the best thing is screening. There is nothing like early signs and symptoms. Most of them, by the time you feel it in your body, almost always is very late.
Something is already happening.
Something's already bad.
Agnes, this is what we were talking about earlier. She said, I did not have any symptoms, and by the time I went to a hospital, I was told it's at stage 2. And talking about screening and how important screening is, can we just really understand screening at its core, why it's important? What are some of the types of screenings that people should know? And then we'll open the floor to the people as well.
Thank you so much, Winnie. Before I go to the screening, I want to agree with my brother here that most of our patients come at an advanced stage. At Texas Cancer Center, most of these patients come at stage 3 or stage 4, where most of the time the treatment might be palliative. And the reasons have been well put. Number 1 is fear of unknown, stigma. Number 2 is lack of money. Generally, they don't have money. And sometimes they ask themselves, where will I get money to undergo all this treatment? And then also ourselves in the community, we also stigmatize these patients. sometimes even from the diagnosis, they don't know who to share this information with. I think from the beginning you asked her how she perceived the information, and I think you heard what she says. That one, she cried, and number two, she accepted. And this happens to all the cancer patients. Now, we can't screen all the cancers, and some cancers are screenable, others will just hit when they're already in advanced stage. Something like a breast cancer, where it's very simple to screen. You just do, we are trying to eliminate the self-breast exam because of not everyone knows what a lump is and how to appreciate the lump. So we encourage the clinical breast examination in the facility. So that's number one. Then that is very simple to do. Just palpate yourself, or maybe go to the doctor to palpate for you, the lumps and all that. Even before you go to the processes of either scans, mammography, or maybe ultrasound, but that again depends on age. Something like cervical is also very simple. For 30 years and above, in Kenya, we target 25 to 49, though in the world is from 21 to 65 years of age. Now, for 25 and above, now there is even HPV DNA kit, which you do it in the comfort of your home, bedroom, or a toilet. Take the sample, you then take to the lab. And if it turns out positive, there is always a core test thereafter, either pap smear or something thereabout. Then we have something thereafter is a prostate, which is even the third. These cancers are also categorized in terms of the burden. One is the breast, cervical, number 3 is prostate. Now, prostate is for the men. A man who is more than 40 years of age, and in this room, I think, if I look at, we are maybe less than 5%. These 5% people should do screening. And the screening is simple. It's a blood test. It's called a PSA. Right? But even if a PSA turns to be high, that is not a confirmatory. There are reasons why your PSA levels can rise. Number one, it could be because of prostatitis, BPH, catheterization, UTI, and so many. So we'll talk to you about these results, but if it is more than 10 and above, then that could be an indicator. Then we have another one called colorectal. Though it's number 5, number 4 is esophagus. There's a reason why I've left esophagus out, because of the screening that we've not got the modalities. But colorectal is also very easy. At 45 or 40 years and above, you can do a stool test, the simple stool. Leave alone the feet. The feet is a bit expensive. What you call there's a long name for that feet, but we can do the fecal occult blood test. Simple stool. Take to the lab. Just look at if there could be some hidden blood in it. Then thereafter, you can now be sent for colonoscopies thereabout. But start with the stool test. Then we have the lung cancer. Now this month is, today is the 4th of February. It's a Cancer Awareness Day. It is for all cancers, but we are trying to limit it to the mesothelioma and also the lung cancers and all the asbestos caused. Lung cancer, people who have been smoking with the PAC years of more than 15 years. All the doctors in this room knows how to calculate the PAC years. Someone who has smoked more than 15 years, there are screen tests for that. We do CT scan, or what you call an uncontrast CT scan, just part of the screening for the lung cancers and others. So you realize the first 3 are very easy. Breast, cervical, and prostate. In fact, even the colorectal, very easy. So please let us go for this screening. They're available in all the health facilities. At Texas Cancer Center, we provide all of them. We have them. We do screening, diagnostics, treatment, and even the palliative care, survivorship, and all that. Yeah, thank you so much.
I see, and thank you so much, George. So we're opening the floor in just a second. Prepare your questions if you have a concern, if you want to share maybe your story or your journey, probably you're a caregiver, feel free to do so. So prepare your questions. Please keep them short and straight to the point, especially if you're asking a question, and tell us who you're directing your question to. But even as we prepare, Mike, to get it to you, Agnes, just to speak to you, in terms of your journey, because we talked about how it's not just financially draining, but it's also emotionally draining as well. So for you, what was that journey like, and especially when it comes to emotion and psychosocial support as well?
Yes.
Speak closer to the mic. Yes.
About emotions, they affect a lot. Because in one time or the other, when you are well, you are not sick, you have so many friends who can ring, who can talk to you, who can visit you when you are healthy. But once you have been diagnosed that cancer, I think some of your friends, they remove your name from their phone. They cannot even ask you how you are, what you are doing. And I thought that thing affected me a lot, but I thought they were afraid for me to ask them for finances. Because some are great, they were great friends to you. They know the journey, they know the treatment is expensive. Like me, I used to get my treatment in Texas, from here to Texas for chemo. I was spending 3 days in an hotel in Europe, and it was expensive. So emotionally, I thought my friends, who were sharing, we couldn't share anything, but after being sick, they ran away from me, and it is not good. And instead of supporting me even with the mouth, even telling me or asking me how I'm doing, they ran away from me. I was left with my dearest friends, those who cared, because there are who couldn't even ask me how I'm doing. Because like getting chemo is a strenuous one, and it is painful, and it can cause you to have bad emotions of even tearing, crying. But when you see your dear friends are not asking, you feel bad, you feel neglected. But still, when you have hope, and when you are saved, and you know that the life is there for you, and you know that cancer is not certain death. It's not death, you can fight it. And even if it's death, you have not, it's not a mistake. You have not bought it. So, emotionally, even your dear ones, they see as if you are becoming abandoned to them, unakuwa mzigo kwa watu. Na hiyo kuwa mzigo, hata wewe inakusumbua sana. When you know you are mzigo kwa watu. Friends, family, they are very supportive. I was supported throughout the chemo for 1 year, radiotherapy, Texas, from here to Texas. Also, I was supported by my family. But then dear friends, in fact, I sympathize with them. I wish they can be tested and then see if they are okay.
That's a beautiful thing to say, because most of the time we stigmatize and we don't know what you're dealing with. Thank you so much, Agnes, for pointing that out. Okay, let me speak to Margaret. Margaret, I don't know where Margaret is there. Okay, let's pass the mic to Margaret. And Margaret Kajuri is Kaguri. Kaguri is a caregiver, to your mother-in-law. So please tell us a little bit about that, and from a caregiver's perspective, just paint the picture for us, how the journey is from your perspective as a caregiver.
Okay, thank you very much. My name.
Oh, please stand. Yes, watu wa nyumbani wakuone. Thanks, Margaret.
Thank you very much. I'm Margaret Kagurisami. And I'm glad to be here in this forum and to speak about my mother-in-law. She was diagnosed in here 2016. And thank God for awareness that is being created every now and then, because that is how my mother got to notice the lump in her breast. She took the initiative immediately, and she went to for her test. The biopsy was positive. And my mother was started on treatment immediately. It was not, and it was not, and it's never a simple journey to work with your patient around you. And as caregivers, we are also, as you are always told, if you are not infected, you are affected, and so the family the family members are affected. You walk the journey with the sick. And as for my mother-in-law, after the chemos, she could come and she had no appetite. You are supposed to keep on trying to see what she can eat. And you can't feel bad even if you prepare one meal and she doesn't take it. You have to keep on trying and to see what she can take in. It's never a simple journey. Financially, people are drained. Their pockets are drained because, again, like for her who used to move from here to Nairobi to Texas Cancer Center, sorry. And then journey, she'll come back. Things are never easy. As for caregivers, you have to show a lot of love and support to the patient. And I thank God that eventually after the treatment, after the chemos and the rest, she got healed, though she lost her breast. We thank God that 10 years down the line, she's a warrior, she's no longer a victim, and we thank God for that.
Much, Margaret. And from your perspective as a caregiver, because you're caring for your loved one, but how would you have wanted to be supported as a caregiver? Because again, like you rightly said, if one of your family members is affected, you're also affected. So from a caregiver's perspective, what sort of care should be given to the caregivers as well, so that you don't forget yourself?
I think caregivers should also be counseled on how to take care of their patient around them, because you feel emotionally drained to having that patient around you, and I think caregivers should be supported emotionally too. Yeah,
I see that. And thank you. Thank you so much for being here today as well. Okay, do we have a question? Do we have a comment? Anybody who wants to contribute to the conversation as well before we come back to the panel, please raise your hand so that we can get the mic to you. Very nice. Okay, okay, let's have him and then we'll come to you. Thank you. Let's encourage him with a big round of applause. Like we said, this is our conversation together. Okay, go ahead and please start with your name.
I'm Patrick Maina. My question goes, I read somewhere that there are this particular pesticide, harmful pesticide that was banned in those European countries long time ago, and it's being smuggled in our beloved continent Africa through our borders like e.g. Uganda and Tanzania. The pesticides are currently being used by our farmers here in Kenya to prevent post-harvest loss. Research was done, and they found out that most of the tomatoes that we do consume and potatoes there are 40% chances that do have those harmful chemicals. And if those who are lucky not to consume the foods, the harmful chemical, there is a chance that it has been during maybe rainy season, or if maybe they are doing irrigation, they are being drawn to our river banks and streams. So I was asking, we do pay taxes to our Food and Poison Board and KEBS, but we find out that you cannot find we do export any food through our country to those countries, but you find out that you cannot find a scenario where a food is being taken to those countries without being tested. And they found out that you as a farmer use the pesticide, they cannot buy from you. Why is it that they are not doing the same in our country? Who are they working for? Is it that we do pay them tax to work for the Europeans, or they are working for us? The second question is that why is it that we don't enlighten our people on how to prevent or to detox this harmful substance through maybe the food that they are safe for consuming or something? Why is it that we do emphasize more on when it comes to maybe treating it or something? Thank you.
All right, thank you so much. Let's appreciate him as well, one more time. Do you have anybody else on that side before we move to this side? Tumeogopa. Oh, there's one actually next to you. Yes. Yeah, please stand. Thank you.
Thank you very much. My name is Eunice Boroki. I'm a nurse and a clinical psychologist. It has been, we've gotten the information that patients come late in stage 3 and stage 4. And this is because of poor health-seeking behavior. And research has shown that men are more prone to that. They seek health when they're too late. So my question is to the Texas Cancer Center doctor, what can you do? How can you bridge this gap?
Good question. Thank you. Anybody else on that side before we transition to this other side? Going once, going twice. Okay, can we answer those as we transition to this other side with the mic? Do you want to tackle the kwanini? When are they tested and whatnot? Just probably think to speak more on our laws and our policies, especially when it comes to such harmful pesticides that are being used.
Thank you so much for that question. About our laws, about pesticides and that. I think on paper, I have read a few laws which are actually very extensive. The only question would come about how do we implement them? Do we actually implement what we want for other people? Maybe that other question would be discussed at a much higher level, probably than this panel, about the implementation aspect. But I do strongly believe it's not because we are paying taxes to pay the other people. It's only that the other people are very strict on what we need to sell to them. But we are not strict about what we sell to ourselves. So the government is not supporting them. They're just putting barriers according to them. We also have these barriers according to us. We talked about partnerships before. This is not something that is being implemented by us, but it should be implemented. I think there are other levels of KEBS, Parliament, and other things that should be able to do that. The Ministry of Agriculture should be able to do that because those myths are actually very much around. And we also know that some certain chemicals are actually very much carcinogenic. But the question is, for that particular pesticide, has it been tested? I cannot talk about particular individual pesticides. And then the last question about how do we bridge the gap? Maybe just to come in there. The greatest thing is to make the person who has the problem get the information. There is something that we say, we cannot audit, or rather we cannot do what we don't know. There is no way I am going to talk about here today what I don't know. There is no way a woman in a village will start coming to the doctor if they have never seen a doctor. A last thing, another concern that came still in that line, most of our patients, most of our people actually do not see doctors in several healthcare seeking points. Still another regulation issue. You will realize that by the time someone actually ends up meeting a doctor, an actual doctor, who actually picks it, is almost always too late. Most of our people in communities actually do not meet doctors. Then number two, those who meet trained community healthcare personnel and the people within the level 1 and within the level 2 service points, there is no, while on paper there could be clear referral processes, but it is not implementable.
Okay.
Yes, that is it.
Sorry, when you say patients do not meet doctors, is it that the specialists are not available, or the specialists want you to go to their private clinics for you to access healthcare,
Okay.
or are they mostly in urban centers? For example, Agnes said she had to go to Nairobi most of the time, spend 3 days in a hotel, it's expensive and whatnot.
We have a problem in sub-Saharan Africa because, as opposed to other developed countries, healthcare is a service of the government. Here, healthcare is a business. So, if we were to look at it, this is a business. And if you go anywhere, any person who sells mboga, even if you have cancer, you'll have to pay your 10 bob to get your mboga. If you now come elsewhere, you'll have to pay for it. Now, one of the reasons, why don't they meet doctors? First of all, there actually no so much personnel who can actually pick these things at the grassroots level. Number two, now if you need to treat cancer, you need to see an oncologist. How many oncologists do we have in the country? Even if you are to do that maths, what they say is not mathing. That it is impossible for all cancer patients in Kenya to see our oncologist. And if they were to see them, even if they were to work 24 hours a day, seeing cancer patients, our oncologists in Kenya cannot see all cancer patients in Kenya. Yes.
Oh, I see that. Mutogi, do you want to chime into that? And then George will come to you to answer his question. Mm-hmm.
My colleague has alluded to a very important factor, and also I'll touch briefly on what you mentioned about partnership, because it has a role to play in terms of meeting the health needs of our community. In terms of partnerships, I think where we have not done so well as a country is there has not been adequate partnership with the community. And I say this because when you say that you see our community members who are affected by cancer seeking healthcare late, there is a gap in terms of partnership between the health, and in this partnership, I want to identify key stakeholders here. The government. He's mentioned the aspect of health regulation. The government plays a very key role in terms of the kind of regulations that are put in place, including testing for anything that comes into our country, in terms of what you call formulation of healthy public policies. For instance, tobacco is known as one of the main causes of many associated with causation of many cancers. But the government needs to put a role. I've seen probably a decrease in the number of people you see out there smoking, but I can tell you tobacco has come back in many other forms. And our community, young people are using tobacco in many other forms. You've heard of velo, vaping, shisha, many other components that government has a role to regulate to ensure that our people are not exposed to what are known cancer-causing chemicals. Secondly, is about now, this partnership is the role of the faith community. I come from Christian Health Association of Kenya, and we see a very important role of the faith community. We say our country is largely, either Christian majority, mostly, at least somebody subscribes to some faith. And one of the avenues you've not utilized to meet the needs of our community, especially education, is the use of the so-called faith community initiatives. For instance, we ask one question, maybe a challenge to all of us, those in the medical profession, a partnership with the faith community. At least once a week, the faith community has an audience with the entire nation. What if we dedicated time during our Sunday services on health, even if it's 15 minutes, and we make sure there is partnership with the health department, those of us in the hospitals and the Department of Health, Minister of Health, dedicate at least 15 minutes and a message is passed across the country. Whether it's Muslim, they can do also on Fridays. And for sure, you'll be able to use those platforms to pass the message. The third stakeholder, a very key one, is the media. And thank you very much for what you're doing here. Can we make this a routine? And I'm glad I heard that you run health a program on health. Can we see more of this in our media platforms, whether the television or even the radio, so that we who are in health, in partnership with our faith community, can be able to come in there to educate our community? Lastly, is about the role of health promotion. What I've mentioned is health promotion. I think we've talked about more of prevention, but when you look at the structure of health, we start with health promotion, passing the right information about what people need to do to avoid or to prevent, to avoid like a healthy lifestyle, healthy diets. Then we go into aspects of prevention, and the government has a huge role to play before now you go into the treatment and the palliative care. And my colleagues have really articulated them quite well. And that aspect of communication will address what my sister, the warrior here, talked about, the stigma. The reason as to why she faced some stigma is partly because probably in the community, they think cancer is contagious. they could probably catch it from her. But we have a role to play so that we destigmatize it from the community level and ensure that there are support structures for people who have cancer or who are at risk of contacting cancer. Thank you.
I see. Thank you so much. And Prof, we'll come back to you to talk about then healthcare financing, because Dr. Griffiths, you said we're a mission hospital. You cannot send, people away. So sometimes probably you're running on losses. So then how do we sort of like balance that where the healthcare, the role really is to provide care to the people who need it, but also, on this other side, like Prof said, we're removing all the roofing and replacing it with something else, which requires money. So healthcare financing, Professor, will come to you to really address that and what ought to be done. But George, you were supposed to answer a question before we take more?
Yes, I wanted to just jump in, but most of the questions have been well addressed by my two colleagues. Okay. But also, just to add, on top of what our sister asked, how we are bridging the gap of the late diagnosis.
Yeah.
In fact, by so seated there, you're already bridging that gap. The reason why NTV organized this town hall meeting is to bridge that gap. And as a team, we are bridging that gap by so sitting here to create awareness and to discuss all these matters. So thank you for sitting here to bridge the gap. Then, about the pesticides, let me just come clear on this.
Okay.
It is not the first time I'm meeting the patients asking me about the pesticides. And I think if you realized I tried to dodge it, the first question you asked. The reason why is that it is not documented. In Kenya, the guidelines that we use even for treatment or even for learning and all that, they're developed elsewhere. We use the NCCN, we use the ESMO guidelines, ASCO. You see, these guidelines are for Europeans, some are for Americans. And this explains the reason why breast cancer in European, especially for the hormonal receptors positive, are doing very well because they go for research. They allow themselves to go for research and for science and for studies. In Kenya, we sit on a research maybe through a myth that we suspect is the cause, but you don't want to go in for maybe a research and so that it can be documented. If I look at all the causes and risk factors for gastric, esophagus, I have never met pesticides anywhere. In fact, they are even saying that esophagus is associated with hot porridge and hot beverages, but it's not documented anywhere. So I cannot say, yes, it is causing that cancer unless, you participate in the research and help us document these guidelines. Thank you.
Or maybe we should start conducting research on that and get to understand why a lot of people are actually thinking pesticides have a direct cause to cancer, maybe?
Right. It could be a cause because there are many literature. Dr. Griffin talked about many papers that he has come across. And it's true, it could be something moving towards that.
Okay.
But is not documented.
Okay.
Yeah.
Okay. Maybe it's an opportunity for you, you to
no
contribute to that.
Yeah.
Professor, you wanted to add on something? Yes.
Something small.
Yeah.
Actually, I'm happy. This forum is answering our concerns. If you listen to our governor, he's saying a statement that I want everyone to hear, that sickness, there is no public patient, there is no private patient. I'm liking this because he's talking this all over, and I think the concern that has been expressed by the panelists and also the concern that is expressed here, to me, I'm hearing it sound and clear, because that's the reason why we really want to have this cancer treatment here. Why? Because we really want to bring the care closer home so that these people will not travel all the way. We started the dialysis the other day, and we are getting referrals from Kenyatta because they are telling them, why go all the way when you have dialysis at home? And this is the reason we want to bring this the service of care at home, closer home. In fact, we're even trying to say, how can we make it affordable? Like these journeys they are making all the time. Actually, we want even to expand this oncology service to the Mwananchi. And then we are struggling so much that we can have something like that. So my answers, these questions are really answering our concern. why do we need a very serious oncology service here in the Meru Methodist Hospital?
I see that. And Agnes, just to bring you, to what Professor is talking about, bringing the services closer to people, because for you, you're not feeling well, and then you have to travel all the way, and then you have to come back home. Like it's a lot, right? So from a warrior perspective, because you're here today to share your journey and tell people, listen, it can be done, it's possible. What are some of the areas that maybe unaona tukifanya, especially hapa within the community, itasaidia watu wengi sana wale wenye they have to travel all the way to Nairobi or other parts of the country just to access healthcare?
Thank you very much. That is good news to hear that they want to start oncology. There's never been there, and that is a good idea, and our people will be relieved. Like me, my breast was removed in this hospital.
Oh, here?
Yeah.
Oh, wow. Okay.
People have never known.
Okay.
It was removed here.
Yeah.
Maybe I was the first person to be removed, and maybe there's nobody else, I don't know. And it was done very well. I got good care. I was in good hands. They were taking me like a person, a friend. In fact, thank you very much, those who took care of me. Yes. So they are my friends. They have not removed my name from their phone. I hope so. So if it's here, so many people are struggling. If they will start, especially chemo, though Meru Cancer Center, they are giving chemos, and the people goes there. There are so many people there. When you go for appointment, you have to wait. The line is big, and most of the people come from Wegembe. I'm sorry to say, because when you talk, we see each other in the vehicle when we are going home. So many people come from here and goes to Meru because there is no other service. It was not done here, like chemo. It was not there. So that one is a very good improvement of the hospital. Keep it up. We shall be coming here, and others, we will inform them. Now, chemo are being offered in our hospital. We will encourage them. It is cheap, even for traveling, because traveling from here to where I was going to Texas, I could not go alone. With this disease, you cannot go alone. With this cancer, you cannot go alone. And you cannot go alone, go and spend a night and another one in the hotel alone. After receiving chemo, there are side effects. So we used to go 2 people. How much? It was expensive. If it was here, we could just walk. They leave me being given and then go.
Mic closer to the, yes.
So it is a good idea, and that means that our professor and other medical in this hospital have seen the need, which has been there. It could have been started long time ago, but the right time, when it's done, is the right time. Keep it up, and please take care of the patient with the cancers, their emotions. So have more counselors to counsel them. Let them be shown love and care. Yes.
Thank you. Thank you so much, Agnes. Again, that goes to say about attitude, because most of us think I only have to go to Nairobi. That is where I'll get the best, the help and treatment. But to hear that is available where people can easily get to, that's a beautiful thing. So we say, Prof. Dr. Griffin, George, good work that you're doing. Okay, let's get to hear people on this side. Question. All right, we have a hand here. Anybody else? Just please lift up your hand so that we see you. There's another hand at the back and then another one here. Okay, so let's start with you.
Thank you. My name is James Kainga. I am a member of the board of this hospital. I also come from the village, next to the village that is christened the Cancer Village. I come from the ward. We share the same ward with that village. unfortunately, I also lost my brother to stomach cancer.
I'm sorry.
So I know, although I know what it means, having somebody suffering from cancer. For that matter, therefore, a day like today is critically important to me. And because it is Sunday, I also lost my mother-in-law to cancer. So cancer is really in this area. In our village, in that village where we come from, just unlike what I heard somebody say, that it is not easy to hear somebody has passed on or is suffering from cancer. Where I come from, it is homes, it is villages, there is cancer. So today is it's a comment before I ask one single question. So today is a very, very important day. The NTV, thank you very much. And particularly the hospital, coming up with the idea of starting a cancer center in our area where we are suffering. If you are not infected, you are affected. The sick does not take care of their own treatment. It is those who are closer to them that they assist in their treatment. And then, because just like the doctor said, the treatment, people it's diagnosed when it's late. More often than not, we end up losing the patient. So much so that people are afraid. There is a stigma going on here. I want to inform the doctors. People are saying that it's better to stay without being diagnosed, because the moment you know you are suffering, you die very fast. That is what I have heard people say. So that is why there is fewer cases that report for diagnosis, because they feel that when they are diagnosed, it was acid in the stomach. That is how he was told. Then he was given for acids, and then I don't know what that time there was no HIV. People were not talking about HIV, which we are hearing nowadays. But he was told of many other things before finally Dr. Warren discovered that he had stomach cancer. So how is it? What can be done to start from the highest to the lowest? Finally, it is good for all those who are listening to me to be in an era of insurance. SHA is critical. When my mother-in-law suffered, she was admitted in this nice hospital here. And it is SHA that assisted us to ease the financial burden. So those of us who are out there, it is important to have an error of insurance. Pay even if you are not sick, because when you are sick, it will come in handy. Thank you. May God bless you.
Thank you very much. I really, really appreciate it. George, was that a question for you? Okay, sawa. Can we pass on the mic to her? Yes, please stand, say your name, and then let's keep the question very short and straight to the point, because I can see our time is far much spent.
I'm Reverend Mary. I work here as a chaplain, and I've had opportunity to interact with people who come here for treatment and others for other interventions. And I want to address the fact that culture here and tradition is also playing part in not diagnosing the disease very early. Right here at our wards, sometimes we are called as chaplains to come and intervene, especially when a patient will think that maybe it is something to do with what they have done to their relatives or what has been happening in their families. I don't know what we call Isharo, professor, and some of them will come here with the relatives coming to say, let us go and Kobatuela Mata, Kobaikiria Mata in Meru here. And I don't know, the prof is going to address that, to redress the situation, because they think it is not medical, it is either spiritual or it is traditional, somewhere it is coming from. But I also want to say that it is the high time that our county and the nation at large, this menace is declared as a national disaster, because it is eating right, left, and center. If you count the footprints of a person from this place to Meru town, to Nairobi, to other places like India, you recognize that there's a lot of medical tourism or some kind. whether it is going to seek for their diagnosis, whether it is for treatment. There's a lot that is going around this cancer. There is a lot of, is it entrepreneurship or I don't know, but there is a lot which is going around cancer. And I pray that our country is taking watch, that they may declare this is as a disaster. The same way we go doing campaigning and doing civic education for votes, then this one can be done so that we can be able to counter this one, because it is eating so much into the pockets of our people. But I also want to say to the ones who have already been diagnosed and they have been...
The question of what next, and even going with the theme, for this year, what next, when it comes to Meru County, and even from the audience as well. Kama unasikia kuna kitu lazima ifanywe leo, tumalize hii maneno ya cancer, also feel free to let us know. But we're taking a very quick break, so do not go anywhere. And like I said to you, our audience who are watching us this morning, have you ever been screened for cancer? Have you ever had conversations around cancer? We'll come back and also get to see some of your feedback after this break. Just stay with us.